The facial nerve tumors are rare. The most common histological type are facial nerve schwannomas. Although facial nerve hemangioma, malignant nerve sheath tumors, and escape lesion from parotid malignancies are also maybe DD of the facial nerve schwannoma. The facial schwannoma are benign, slow-growing tumor arising from Schwann cells within the nerve sheath. Facial nerve schwannoma can arise from anywhere along the course of facial nerve from CPA to the ramifications within the parotid. The presenting symptom will vary according to the segment involved. The relative frequency of occurrence at each site varies has been reported to most common at geniculate ganglia, labyrinthine segment, tympanic segment, and mustard segment. So most commonly, geniculate ganglion part is involved. The common clinical finding is progressive weakness or spasm of the face is common presentation. If you see the T1 weighted image of this patient with gadolinium enhancement, you can see there is labyrinthine tail sign. It means the geniculate ganglia having tumor and labyrinthine segment is enhanced. So this is called labyrinthine tail sign. And this patient present with the facial weakness. Similarly, if you see the T1 weighted image of this patient which is showing facial schwannoma filling the internal auditory meatus and extending along the greater petrosal nerve, you can see in this picture. So this is the enhancement of the greater petrosal nerve by the geniculate ganglia tumor. So this patient also present with left side facial weakness. So this is the common presentation. If you see another patient of this MRI in coronal section showing the geniculate ganglia tumor which extending in the petrosal foramen as well as the temporal lobe of the brain. So this is aggressive schwannoma which is extending to the brain. So mainly investigation you can do MRI as well as electroneurography. So these two investigation is more than sufficient. As you can see, this is the picture of the CT scan of the temporal one showing smooth enhancing lesion on the geniculate ganglia. It is not a restrictive lesion on the left side of the geniculate ganglia tumor. So investigation you can do only MRI and electroneurography. Rest you can do audiometry and electromyography to if it is lesion in more than. For most of the patient, observation is more than sufficient. For patient with facial nerve schwannoma and good facial function, about grade 1 to 2, then it is observation is recommended. If tumor is enhancing, enlarging, then surgery is recommended. Stereotactic radiation therapy is not going to be helpful. So surgery may be you can do near total or subtotal excision in attempt to maintain nerve integrity with the option of surgical resection, and there is another you can do facial nerve preservation with stripping of the tumor, and you can excise completely tumor and you can do primary anastomosis or cable graft according to the situation. And this is the T1 weighted image of the facial nerve showing facial nerve hemangioma in honeycomb appearance. As you know, the main differential diagnosis of intertemporal facial nerve schwannoma is a facial nerve hemangioma. Clinically, these are associated with significant worse facial nerve dysfunction than the facial nerve schwannoma. There may be similar appearance to the facial schwannoma in imaging, but there is hemangioma is slightly subtle differences. Like it is having don't have any capsule, so this is expansive lesion with honeycomb appearance on the MRI. And surgery is the principal management of this facial nerve hemangioma.